Hello, and welcome to another edition of Health Matters. I'm Dr. Bruce Karlin, and speaking to you from the studios of WCCA TV, who brings this show to you along with the Worcester District Medical Society. Tonight, I am delighted to have our guest, Dr. Gary Blanchard. His bona fides are a little too long to read here, so I'm just going to tell you that when we need a geriatrician in our office for our families or for our patients, Gary's our go-to guy. Great to have you here, Gary.
Likewise. Thank you for having me, Bruce.
Well, I think we're going to talk tonight on a very important issue, which is the matter of getting health care proxies. We framed it as getting health care proxies, but in fact, it's really that discussion around the end of life. And we worked together at St. V's years ago, and we had great discussions with our palliative care team. And the thing that struck me at the time was the number of patients who hadn't made these decisions and had unnecessarily complicated, painful, dying days, as opposed to making your decisions early and having a good discussion and not being overly aggressive where it was purely futile care. And you were great in those committees, so I've been waiting to have this show with you forever, it seems. So why is the health care proxy so central to this?
Great question. So to me as a geriatrician, it really comes back to the average person I see in the office, let's say, is about 84 years old. They oftentimes have maybe 5 chronic, really life-limiting medical illnesses. They're oftentimes on double-digit medications, some
double-digit meaning 10 or more.
10 or more, definitely,
yeah, right,
yes.
Yeah, okay.
Some,
I thought,
many hands, multiple hands of medications. And, so oftentimes I feel like you can get lost in, the organs, you can get lost in the diseases. But if you pull back a step and say, this is what geriatricians try to do, this is what I try to do, is say, what matters most to you? What's most important to you here? To some extent, what's your story? What are your goals? What are we fighting for? Let's do this together. Let's do this collaboratively. Sometimes that can be, I want to live at home no matter what. It might be hard, but that's my most important goal. Sometimes it might be, I'd love to keep being able to walk up the stairs so I can see a grandchild and play with a great-grandchild on the second floor. So if we start with the premise of understanding what matters most to someone, what their goals are, we work from there. And if you're not also in parallel, in tandem, making sure that someone has a healthcare proxy, then sometimes your work with addressing what someone's goals are, what's most important to them, can be for naught. Because Massachusetts is a little different than most states, than many states, in that in most states you can write down on a piece of paper what matters most to you. You can write it on a living will. You can go to a lawyer. Massachusetts is different. Massachusetts, you can write down on a piece of paper. You can visit the lawyer. This is what matters most to me. Under no circumstances do I want you to do, X,
A,
Y,
B,
or Z.
C,
Exactly. But if the healthcare proxy, the person that you appoint, the person that you designate to be the person to make decisions for you, if something, God forbid, were to happen, like let's say you had a stroke, let's say, God forbid, you were in an automobile accident and you weren't able to make decisions for yourself, which, spoiler alert, will happen for most of us at the end of our life, then you can talk all day to me about this, which, I hope I enjoy doing that. That's an important part of my job. But if you haven't named someone to be the proxy, to be your medical decision maker, if you're no longer able to make those decisions, then the proxy really, that person can do what they want rather than maybe what their mother, their father, their spouse might want.
So I'm just thinking back to the multiple patients that come through, and you're trying to get this healthcare proxy at the worst possible time.
Yes.
It's the patient is in the emergency room, and they've just had the stroke or the accident or whatever it is, and you say, who do you designate? And you haven't had the discussion, so the person that you designate, well, it's my son, but he's in California and I haven't talked to him. And you get these weird decisions, and I really think they're weird decisions that if you thought for more than 5 minutes about it, you'd say, geez, Dad never wanted to die not being able to think, and yet the long-lost son comes in and says, well, I haven't had a chance to say goodbye, and keeps them going.
The odds of these decisions happening how a patient would want them to happen if we're first discussing this, reflecting upon this at, say, 3 a.m., at, say, crisis, at, say, the emergency room, the ICU.
Yeah.
If we're talking about this for the first time in those situations, oftentimes we're going to default to doing everything, whatever that entails.
Well, we did some work together way back when, and we had some interesting statistics, and the ones that I remember, and maybe you remember the study better than I do, but of 86 patients resuscitated in a year at a particular hospital, 86 resuscitations in 80 patients. That means that 6 patients were resuscitated more than once. Of those 80 patients, only 16 survived the hospitalization.
That hospitalization.
They checked the records going to obituaries and the like, and they found that of those 16, 8 were dead within a year. Of those 8, 5 had coronary procedures beforehand. So it was sort of predictable that they could have an event that would require a resuscitation. And that leaves 3 patients that may have been helped. And it turns out that some of those were lost to follow-up. So there's only 1 patient of the whole group that we were able to say, yeah, we know what happened. But it was astounding statistics. So that decision for resuscitation is an important one, but maybe the decision's already made when you're having that event. My takeaway from that was that if you're having a cardiac procedure, get the resuscitation for the week afterwards, because that may help. But other than that, the value of the resuscitations was minimal. But some patients say, I want everything.
Mm-hmm. And I certainly endorse what you're saying. You and I worked on that together. I would say that sometimes, we're talking about a do not resuscitate order. Sometimes that is wrongly, but understandably misinterpreted by patients as do not treat, or we're going to withdraw care, which we never withdraw care.
It's actually quite the opposite.
It's actually quite the opposite. If anything, it becomes more aggressive. I'm happy to flesh that out for sure. I'd also pull it back a bit and say, sometimes I think when we're talking about goals of care, I find this in the hospital with, attending physicians, resident physicians, nurses. We tend to focus on, like when we're talking about resuscitation, we've lost someone, they're not with us at that moment. And I think sometimes when we talk about proxies, we talk about goals of care, we focus on the very, very end of life. I also think it's important to reflect as much as, if not more so, on all that comes before it.
So actually our start leading with the
Yes.
resuscitation is 180 degrees wrong.
I don't. I think 180 degrees would be extreme. I think that this is important, and I think if you ask the average person who understandably would get their understanding of what resuscitation, what CPR, what a respirator means, comes from television, and on television they've certainly done studies on this. The vast majority of the time, people will leave the hospital, including older adults. They will leave the hospital after a successful resuscitation by George Clooney or Anthony Edwards. They will leave alive, walk out, end of episode. That's how I think a lot of folks
better than when they came in.
So,
which is rarely the case.
I agree. It's not presented as we can do these things, but let's talk about what that would mean and what that would look like. Would someone rally to how they would look beforehand with their mind and their body? Sometimes we could bring someone's body back, but there might not be a chance we bring someone's mind back. So I think we have to talk about very end of life, but I also think it's important to emphasize in the months before, because while this statistic has gotten better nationally in recent years, it's still about 1 out of 3 people over the age of 75 at the end of their life will spend a fair amount of the final month of their life in an ICU. Even though when we ask people and we reflect, we do surveys, we reflect with people, what would be most important to you if things weren't going how we would all want them to go? If we were talking maybe days or weeks, and the vast majority of people would answer home, but oftentimes for a whole host of different reasons that you and I have talked about over the years, that doesn't happen. Home doesn't happen, and end of life happens in an ICU. So I think it's really important in the months and really years to destigmatize this issue. In the doctor's office, we bring it up. We check somebody's weight. We check their blood pressure. I think we should be asking about a healthcare proxy at every visit. We should be asking about goals and what's most important, what matters most at every visit. The theory being that if we do that for years in advance, maybe that son from California is on board, is aligned with what we're talking about, and people have had a chance to reflect over time.
So getting back to how we make that happen, there are various forms. There's most forms. There's other forms that people can fill out that say, these are my wishes. But in Massachusetts, what you're saying is the person that makes that decision when you can't is going to be the person you signed over to the healthcare proxy. So it's critical that you have some discussion with them.
Agree, and I've learned that over the years. I can think of a few patients over the years where I would have someone in their 80s or 90s, and hadn't seen a hospital since childbirth, and they were very functional, they were independent. I was trying to really promote their independence over time, and when they would interact with other doctors, say, yeah, I know they're 90, but they really are sort of functioning more at a 70-year-old. But at the same time, at 90, of course, anything can happen today, tomorrow, and we can't, predict that. So even when we do talk about it, I found that there were a few times I remember that I felt like the patient and I were totally on the same page with goals and what was most important, code status being, a part of that. Yep. But because they were driving, because they would come to the appointment by themselves, I didn't necessarily always reach out to the proxy because the patient has capacity and we could do all of it. So I sort of learned over time that even in that situation, we still need to align the proxy, because even if I say, I have spoken to this patient many times, she's been unequivocally clear to me what her wishes are if this were to happen, this exact scenario were to happen. If the proxy comes out and says, I don't think that's the case, my mother would want this or that, and maybe they're understandably overwhelmed. They're not sure what to do. They're afraid. Those are very understandable emotions, and I think I can't hope to fully unravel that meeting someone on the first time. So it's really important to make sure that we're aligned, but also that you at least encourage, you have someone fill out a healthcare proxy form, and that you at minimum encourage as their doctor the patient to talk to the person who they've named and they've at least run through some scenarios. We can flesh out, there's more advanced forms, there's more advanced ways to have these conversations, but at minimum, to name a person, because if you don't name a person, a court, a lawyer, could. So Massachusetts is very important for that. There's some different next of kin laws, we would call them, in the policies in hospitals. But the bottom line is Massachusetts is, if the patient is incapacitated, meaning they're no longer able to tell you what their decision would be, sort of reason through the pluses and the minuses, consider alternatives, tell it back to you. If they can't do that for whatever reason, then that becomes a decision of the healthcare proxy. Even and legally, they can make the medical decision. Ethically is a different conversation, but legally, medically, you are supposed to follow the healthcare proxy.
I'm going to bring a fly in the ointment here. We have colleagues that aren't as accepting of the healthcare proxy's wishes. I mean, they do, because legally they're bound to, but it's important to have your other doctors on board as well.
Agree.
Which is, why it's so important to have a primary care or a geriatrician available to rein in well-meaning but perhaps overly aggressive specialists that say, geez, I really think I can do something, when a patient has described other wishes. You have experience with that?
That was a knowing smile, Bruce. So I feel like our job should be the quarterback and the coordinator in these situations. So certainly the cardiologist should know, their cardiogenic shock better than I should, the nephrologist, all of that. But I should know the person the best. I should know their wishes. I should know their baseline. I should know their values. I should have had these conversations over time. So my job would be to advocate in that situation, whether it's a proxy or maybe a proceduralist, whomever it is. Yes, the proxy, let's say, can make that decision legally and medically, but that doesn't just mean I'm going to say, I'm not sure exactly how you're feeling. I'm sure this must be overwhelming, and, I can see that you love your dad very much. Let's just talk about maybe what you understand about all of this, because this is a lot. Tell me, where are you coming from? How are you feeling? Tell me a little bit more about your dad, your relationship with your dad, because sometimes we sort of start wagging a finger or say should or shouldn't, and that's not really aligning with someone. It's not really giving the benefit of the doubt. So especially with the proxy, this is oftentimes the worst day of their life, and to give them the benefit of the doubt, as opposed to the hard sell about doing this and doing that. Do you really want your father to suffer? Do we really, ultimately, I think there's a way to align where we just sort of sit down and listen. We actively listen. Doctors are, I think, a bit notorious for talking and interjecting. So I think to actively listen in those situations is helpful.
I think our watching audience will understand that you do this exceptionally well, and that it's a real skill. I just wanted to make a plug for something that we advocated before. We had suggested to the Medical Society, we may have gone a little bit overboard, but we suggested years ago that a healthcare proxy be a condition of automobile licensure, which I thought was a great idea. But everybody said, well, that's pushing it a little bit more than you should. But the sentiment behind it is absolutely right. Everybody should have a healthcare proxy, because you don't know if you're going to be a 19-year-old that went on a joyride and went skidding off the highway. It's so that it's important to have somebody there. And at the time, we were suggesting that the registry be repository for all of these healthcare proxies, you do need a registry someplace. But that idea sort of gets beyond the thing of saying, well, we got to do it when you're old. You got to do it. Well, you got to do it when you're young. You got to do it when you're middle aged. You got to do it
18
when you can't make those
I have one.
predictions. I've got one too, and I've had it for years. Probably preceding the work that we did together some years ago. But I think this whole thing is just so important to align your wishes, and because nobody knows exactly when they're going to die.
I liked our idea. It was really your idea, and I was championing it. Happy to pat you on the back for that. But I do think, especially in Massachusetts, where we're one of the states that are not a living will state, and it's all about we call it the surrogate decision maker, when an individual can no longer promote their own autonomy, that can no longer make their own decisions, that defaults to the healthcare proxy. I also advise people, it doesn't have to be your spouse. It doesn't have to be the person that loves you the most. It can sometimes be a friend, someone, your best friend, maybe someone who's just one, Kevin Bacon degree removed from the situation. Because to me, the person who would make the best healthcare proxy would be the person who would be able to channel what the patient would want, not what you would want or what you think is right. It would be someone to say, what would mom want in this situation, not what do I want done unto or for mom in this situation.
And perhaps having someone who's a little bit detached might not be as emotional at the moment and might actually conform to your wishes better.
And I'm not discouraging, having a spouse as a proxy. My spouse is, my wife is my proxy. At the same time, the person that you would be most comfortable with to channel your wishes in that moment, which can sometimes conflict with what they would do if it was up to them. But to me, what do I know? But, from a humble perspective, that's love, to be able to say, I might do this in this situation, but what would my husband want me to do in this situation for him if he was here? If he was here, what would he tell me to do? To me, that is love, and that is making a difficult decision.
So, Dr. Gary Blanchard, could you give us a little bit of time to explain some of these more advanced forms and how you think they help or inform the healthcare proxy? I gather that what we're both pushing for is that everybody have a healthcare proxy. But many physicians will give you a MOLST form. Could you go a little bit through that? I'll just have to give a little personal history here. I have tried to fill out the MOLST form. I find it difficult.
Agree.
This is one of those things where you say, geez, we're asking a patient to make these decisions that I, as a physician, have difficulty getting my arms around. But maybe you've got a slightly different view of that?
The MOLST forms are not my favorite form. There are...
What does MOLST stand for, Ken?
Thanks for taking us back. So that's, it's Massachusetts' Medical Order for Life-Sustaining Treatment. So what's different about a MOLST form is a MOLST is an order. It's not just a piece of paper with preferences written. It's actually like a medical order. Healthcare proxy, more of a legal document. This is a medical order that if I sign it as the patient's primary care physician, if the patient or their proxy signs it, that is binding wherever you are. If you're in an elevator at a department store, if you're in the assisted living facility, if you're in the hospital, certainly, if you're in the nursing home, if you're in your own home and the paramedics come, it's an order that needs to be honored by law for paramedics, doctors, and nurses. It specifically focuses on at the very end of life, about when your heart stops, when your heart is no longer beating.
So when it's no longer beating, the order would say, do not resuscitate or
Exactly.
resuscitate.
Exactly. You stop breathing, you have difficult time breathing.
Intubate,
Exactly.
don't intubate.
That's the primary focus. So that's an order, a DNR order, a do not resuscitate order, a DNI, or do not intubate order. So when we do that, that's an order, that's binding, with the exception of a healthcare proxy can say, and tear it up. The healthcare proxy is the only one. If the patient has the ability to make decisions, they can change their mind. Obviously, we support that. Healthcare proxy, if the patient is incapacitated, no longer able to make decisions anymore, they can also do that. So when I say it's binding, that's for doctors, nurses, paramedics, but at the same time, a healthcare proxy can overrule that. Now, the MOLST form focuses mostly on end-of-life care when the heart stops or you stop breathing. There are, if you flip the pink piece of paper over on the other section, there's check boxes as well that are also orders about, would you want dialysis? Would you want artificial nutrition, artificial hydration, meaning tubes, stomach, nose, mouth, different tubes where we could give fluids or food to give artificial nutrition to someone at the end of life. If I was designing the form from scratch, I would flesh that out more. So what most other states do is most other states will talk about, I think more in a more patient-friendly manner, say, we're not going to be able to exactly predict what's going to happen, but what will probably happen is that we'll say either someone's not doing well, their prognosis is not good, we worry they've been down too long, and maybe we brought their body back but not their mind back, or they're doing well and we think these aggressive interventions could be helpful, but most of the time it's in this gray middle where we're saying, how aggressive would you want us to be and for how long, just in general. I find that sometimes the check boxes, you can lose the narrative about what the goals are.
So in general, this is just getting into a gray area where it's hard to predict. And this was the trouble that I have with them. As our audience can probably see, we could probably go on talking about this stuff for another week or so, but we're really coming to the end of our time here. Do you have just a final 10 seconds to tell us what you think the most important takeaway is?
Talk to your doctor about this early. If you wait till the very end of life, we're going to miss it. Early, destigmatize. This is a normal thing to talk about to honor your goals.
Thank you, Dr. Gary Blanchard. This has been another edition of Health Matters, brought to you by WCCA TV and Worcester District Medical Society. I'm Dr. Bruce Karlin. Thanks for watching.